Hi, this is Mary Jane Woods, and I'm an acute nurse practitioner student, and I'm here to present a case. This is a male patient. He's a 27-year-old gentleman who brought by his parents to the emergency room with complaints of fever, which is his temperature is 104 Fahrenheit, chills and chest pain, described as a pressure at his chest. He has no prior history of cardiac disease, but he was recently admitted to the hospital for MRSA, methicillin resistant Staphylococcus aureus bacteremia, and sepsis with unclear source of infection. So he stayed in the hospital for a week and was discharged after placing a PICC line by ID and started an IV oxacillin for 2 weeks per infectious disease doctors. After 1 week, he presented back to the hospital with this admission and with fever, chills, and chest pain. Sepsis bundle was started. That's include blood culture times 2, CBC with differential, CM complete metabolic panel, checks X-ray was done, and also EKG and a cardiac enzymes that including troponin was obtained. With that cardiac enzymes, his CK upon arrival was about 1455, and they repeated after 6 hours, and it shows about 736. It's still extremely elevated, but what kind of caught or stand out is the troponin was 50 upon arrival at the in emergency room with non-STEMI, or his EKG did not show any ST elevations at all. So with that presentation, cardiologist was consulted, and they did talk about it to doing a cardiac catheterizations, but because of the elevated troponin, but it was immediately dismissed because of possible sepsis. Um, Prior to admission, or a week prior to this admission, patients they did an 2D echo, and it shows that his ejection fraction was 60%. So with this admissions, I'm sorry, with this admission, they did a TEE at the bedside, and it shows aortic valve endocarditis and with abscess formations, and also a mild aortic regurgitation. With also with what they saw too with the TEE, that his ejection fraction or his left ventricular functions, it kind of went down to 45% compared to 60% that was done a week prior. So to confirm what's going on, they did a CT angiogram at the same day, and definitely it was a confirmed diagnosis that the patient has a pseudoaneurysm that involving the aortic root. So with that diagnostic tool that was done, CT surgeon, cardiothoracic surgeon, was consulted for urgent surgery to replace the aortic valve and the aortic root repair. To replace the aortic valve and to do aortic root repair. So, patient has a past medical history and past social history. Patient has the only things that done, or surgery that was done, and he had an ankle surgery in 2010, and of course this past admission with a sepsis, positive MRSA bacteremia. Patient doesn't have an allergy, no known drug allergy. So his current medications right now is oxacillin sodium 2 grams IV every 4 hours, and also gentamicin 1 gram every 8 hours IV, Lipitor 20 milligram bedtime, 1 tablet at night, Protonix, which is 40 milligram daily a day, aspirin at 81 milligram daily a day, metoprolol tartrate 12.5 milligram twice daily, and also Lovenox at 40 milligram daily, which is a sub-Q. Patient has no, social history. Patient doesn't smoke, doesn't drink, doesn't do drugs. He is single and he lives with his parents. His profession, he works at University of Texas as an assistant professor. Family history. Both parents have a diagnosis of hypertension, and both parents take blood pressure medicine. Subjectives or review of the system. His skin, hair, and nails. Um, no denies any lesions, rashes, or any redness. His lymph nodes, it you can presence of a mild enlarged lymph nodes. His bones, joint muscles denies any fractures at this time or stiffness or weakness. Blood denies any bruising or any recent bleeding. Head denies any syncope, passing out, or any headache or any memory loss. His eyes denies any visual loss or any inflammation of the eyes. Ears denies deafness or any discharge of from the ear. Nose denies any nasal drainage or any obstructions or any bleeding at all. His mouth denies any soreness, bleeding, or any jaw pain. Throat, voice, his voice is clear and denies any hoarseness at all. Neck and breast denies any neck pain, swelling, or stiffness. Respiratory denies any shortness of breath or wheezing. Cardiovascular complain, of course, he complained with chest pain that described like a pressures, like somebody sitting on his chest. GI denies any abdominal pain or any complaint of nausea or vomiting. And GU denies any pain at all. He does void, and he denies any pain when voiding. With objectives, vital signs, his pulse is a little bit in the high side. His pulse is 102 beats per minute. His blood pressure is about 153/79, which his parents and he said is a little bit elevated for him. His respiration is between 25 to 30 breaths per minute. But this and his O2 sat with at 2 liters nasal cannula is about 98%. So his general appearance is he's 27-year-old male, Caucasian male. He looked flush and red. He has a red hair and flush and red, and but he's alert and oriented times 3. So objective, which is head, ears, eyes, and nose and throat. His head is normocephalic, no masses or lesions. His pupils, his conjunctiva is clear, and his sclera is wide, and has a normal JVD or jugular. There's no jugular presence of jugular vein distension. With his neck, there is no masses, or tenderness, and you can feel the carotid pulses. Lymphatic, of course, his lymph nodes is a little bit enlarged, mildly enlarged. His cardiac, he's in regular sinus rhythm or heart rhythm. Absence of gallops or murmurs. I did not hear any gallops or any S3 or S4 extra heart murmurs. But he does complain of chest pain and pressures at his chest. His abdomen is soft, tender, without masses. I did no presence of masses. Bowel sounds are presence of all quadrants, and there's no sign of organomegaly or hepatomegaly at all. His extremities, he moves everything, here upper and lower extremities, and he doesn't have a swelling of the legs, and his absence of bruise or any cyanosis or any lesions at all. Musculoskeletal, he's weak, but his gait is normal. Joint and muscles are symmetry, and no swelling at his joints at all. So with the laboratory tests, you can tell with the CBC that his white cells is elevated is about like 20, or his red blood cells is about 3.32. His H&H is normal, it's 10.1 and 30.7. His chemistry, his BUN and creatinine is like 9 and 0.9. BUN is 9 and creatinine is 0.9. The CK upon arrival is about 1455, and it repeated after 6 hours and still elevated. It's way above normal. It's about 739. Um, Troponin though is 50 and platelets is about 687. So patients got admitted in the ICU, and we did a diagnostic test that include the chest X-ray, and his chest X-ray is normal. His TEE, which is definitely that was done at bedside, shows aortic valve endocarditis with abscess informations and a little mild aortic regurgitations, and his ejection fractions was low compared a week ago. It's estimated about it went down from 60% to 45% from the last echo. And with that said, CT angiogram, we did a more diagnostic tool with the use of CT angiogram, and it shows possible pseudo aneurysm involving the aortic root. So assessment after the labs and after history H&P, good H&P, and after diagnostic data or diagnostic test was done, and TEE done at the bedside. Of course, CT angiogram was done. The plan is patients definitely has aortic valve endocarditis with presence of abscess and pseudoaneurysm at the aortic root. With that diagnosis, a CT surgeon was consulted to do an urgent, not emergency, but urgent open heart surgery to replace the aortic valve and to fix the aneurysm on the aortic root. And the plan is not to use, even though he's 27 years old, and mostly with that age, you need to use a mechanical valve. But because of his risk of having infection and his most recent sepsis or bacteremia, the plan is to put a tissue or PIG valve because of the high risk of infections and endocarditis. And ID also is on board, and it was consulted, and is to continue the IV antibiotic that he's getting, which is the gentamicin and the oxacillin after the surgery for the next 2 to 4 weeks per infectious disease doctors. Again, this is Mary Jane Woods, and thank you.